Thank you very much for all coming to hear about the new things in retinoblastoma today. I found out a few days ago that I was going to be in Mexico City, and Efren Gonzalez connected me, and here I am. So thank you very much. Our new goal in retinoblastoma is to have it be the first cancer that has 0 deaths worldwide. And you may say, how possibly can that be? But it's very clear that we can get there. I have no conflict of interest. I'm paid a salary by the hospital for sick children for seeing patients. That covers none of my research time. And all the rest of it is volunteer organizations raising money, TELUS donating to the database I'm going to talk about, and a lot of support from the Paul Fingers work in New York, both directly from the Eye Cancer Foundation, but also through the Princess Margaret Cancer Foundation. Pretty cute, eh? His parents who are very well educated in Canada, did not notice the strange white reflex in his eyes because it was in both eyes. And eventually they did, somebody pointed out there was something strange about the eyes, and they went on the internet, said our kid has retinoblastoma, and that's what both eyes looked like. So his tumors weren't big enough to be killing him if we treat them well, but they certainly are very blinding tumors. His maculas are under tumor here. We're doing pretty well with the right eye, but not so well with the left eye for vision. So I introduced that just because early diagnosis is the most important thing in retinoblastoma. But also staging, and I'm going to jump into the issue of staging. You probably all know that retinoblastoma is classified as A, B, C, D, E, right? Not true anymore. Forget it. And I'll show you why. This was the first effort to stage the eye for, all of this is with respect to saving an eye, not necessarily dealing with life. But Ellsworth and Rees put together the first staging. It was based on the likelihood of the eye being saved by radiation, external beam radiation. Then Lynn Murphy, after 10 or 12 years of international work together to come up with a better staging that was appropriate for the base treatment being systemic chemotherapy, he put forward this and wrote the beautiful paper on the reasons to stage eyes in 2005, and it was A, B, C, D, E. The problem is when we look at this data, which is data from a staging survey we ran with more than 3,000 eyes from many centers in the world, the E's ended up above the D's, so this classification was not perfect in that way. But in 2006, the Philadelphia group published very similar initials and A, B, C, D, E, and it resulted in no paper knows what you're talking about. You don't know what a D or an EI is. Is it an EI by the Philadelphia classification or by the Murphy classification? And you can see here the C, D, and E in the Philadelphia classification are all the same for outcome. So you can't tell. That led the data classified like this. If you try and save an EI, it would be no different than trying to save a DI. So you don't know which meant you could try and save all eyes. E was meant to mean enucleation because that saves a child's life by getting rid of the eye that's at risk of killing the child. But we lost all of that in these classifications. Most of the publications don't even tell which one they're referencing, so that which one they're using, so the data's useless. You can't do a meta-analysis on all the literature on retinoblastoma because you can't put the data together from different papers. So we did this survey. We also included in our survey comparing we actually did another one because there was a different classification that was even dumber than all of these, and including the tumor node metastasis, which is the classic way every cancer is staged, except for retinoblastoma previously. And this also was kind of a mess, not very useful. And then as a result of this, an effort led by Ashwin Malapatna, who's from India and now in Adelaide, Australia, to update the cancer staging manual. So this book is about this thick, and it has one chapter on retinoblastoma. There were many authors, including me, working together on the details. An important part of the details of the 8th edition is looking at this data, which is published in the AJCC, published in this 8th edition book on cancer staging. And then we took the outcome of the new staging and we ran it through the same data set. See if we had done a good job. And we did a pretty good job, because in the 8th edition, exactly the same patients. A and B are virtually the same in all of them. C is clearly better than D and E. And so this is the way you want your staging to look. So you know that if you call it a C, you should treat it a certain way, and this is the likelihood to save the eye. We won't know for sure if that works. The data going into this was from 2001 to 2011. And I'll talk about some of the things, and you know lots has changed in the treatment of retinoblastoma since 2011. So the next edition will be looking at the patients treated using this staging and evaluating what needs to change in 7 years when they redo this. So here it is, just comparing. Again, you can see burr-free, A, B, C, D, E, and C, D, E are completely the same for the A and B, and different in a very interesting way. It gets simpler in the new classification. Any subretinal fluid is C, which would have been C or D, depending on the amount of fluid, is now T2A. If there's any seeding in the vitreous or subretinally, it becomes T2B. So it's easier. And the exact features in the T3, which is all ones at high risk that the tumor's about to or has already spread outside the eye, are spelled out here. And the worst one is aseptic orbital cellulitis as the highest risk factor, mainly because it's not recognized to be dangerous. Not recognized to be retinoblastoma. You can't see anything in the eye. What Ashwin led our retinoblastoma staging to do is move ahead of all other cancers to acknowledge that cancer is a genetic disease. You all know breast cancer has a strong genetic influence, but we had to really argue with the chairs and the boards of this big book to get heritability in it. And HX means you don't know. So that would be a unilateral, or where you haven't done gene testing and you don't know if the patient carries a mutation in the RB1 gene or not. H0 means you've proven that that patient doesn't carry the family mutation. You need to know which mutation you're looking for. H1 is any bilateral. You don't need to have genetic testing. You know they all carry a mutation in RB1. And if they have trilateral disease or a close family history of retinoblastoma, or they have a measurement of a blood RB1 gene mutation molecularly. We've added in the asterisks for special case of considering residual risk, where the testing would say it should be H0. We can't see the known mutation, but our sensitivity isn't good enough in the technology to rule out very low-level mosaicism, and the patient could still carry, even in their germ cells, a few cells that carry that mutation. For example, the parents of a child. But I won't go into that in more detail. So here's retinoblastoma worldwide, and pointing out how important early diagnosis is. In North America, 3% die, and in Canada it's about 2.5%, but almost all the cases in Canada who have died of their retinoblastoma have died by pathology failure. So the pathology was done, the sections were looked at. In one case, the tumor in a vortex vein in the middle of the sclera was there in the picture, but that was the only indication there was high risk in the pathology, and it wasn't noticed. In another case, not enough slides were cut. So the area where the tumor was invading outside the eye were in the paraffin block until we went back later after the child had metastatic disease and found the pathology error. So pathology for retinoblastoma is really, really, really important to save these eyes. And that's why we think we can get to zero death, because by fixing those problems, by identifying them, we can fix them, and the children won't need to die, won't need to get metastasis. But in a large part of the world, 70% die. And really, it's the most important thing is this delay in diagnosis. So how can we get to zero deaths? Early diagnosis. Leukocoria is hugely important and not well recognized in the lay population for what it means. But today, most families see the white pupil, go to the internet everywhere in the world, find the map, maybe, that I'll show you in a few minutes, and find that their kid could have retinoblastoma, and take it forward to the healthcare system that's available to them. And they get told, don't be silly, that I don't see anything wrong with the kid's eye. Someone looks with a flashlight. This could be in the United States, could be in Mexico. The pediatrician, the general practitioner, and even the general ophthalmologist might look quickly and not notice that it happens to be retinoblastoma. And particularly early onset strabismus, or acute onset strabism, or loss of vision, and orbital cellulitis, which is a big masquerade. And we had a case 2 years ago in Toronto that was extraocular retinoblastoma with orbital cellulitis, and our whole team at Sick Kids delayed and delayed and delayed, thinking it was trauma. We were dead wrong. The child survived because we could do stem cell transplant and radiation of the orbit. So where are all these children in the world? There's about 8,000 newly diagnosed kids in the whole world. Mexico can predict 146 a year based on the birth rate and infant mortality rate. Canada has no business specializing in retinoblastoma. We only have 23 a year, but we've gone deep into the science around it, and that's justified us doing our work. India has the most because they have the highest birth rate, and China has the highest population, but not a high birth rate. But China has a very interesting model that I won't talk more about, except that one doctor, I will bring his name up later, sees probably half the patients in China each year, because he travels between 28 different cities every night. He's on a plane to the next city where he sees 50 patients. And then he leaves a team, all highly trained in every one of those cities, in the whole process and the guidelines for treating retinoblastoma. So where are the children? Helen Damaris did her molecular PhD in my lab, and discovered retinoma, which I won't talk more about, and then really wanted to do world health and education. And so one of the things she's developed is this map. You can all go to it easily, 1RBW for One Retinoblastoma World, and actually on the map, but I won't take time to go into the map. Logged in now. This is what it looks like when I log in. And all the little green symbols are retinoblastoma treatment centers that we've been able to map by September last year. And each year we have to go back to the centers and ask them we have summer students working on this, and they phone, email, fax, every way to update the statistics on each retinoblastoma treatment center. And I went to Mexico, and I could see that looked like 2 centers, but there aren't. There's 2 centers in Mexico City that are on the map, and 1 in Guadalajara. And that's where retinoblastoma is treated. We don't know about your hospital treating retinoblastoma, so we must get you on the map. And what I hope is that all the centers in Mexico, certainly in Mexico City, would be working together on MAT, which you're doing anyway, but have it all combined as a retinoblastoma program wherever the child happens to go for the next piece of care. But because you have to update this map manually, essentially, it's always out of date and has minimal treatment center details. So that will work very well with our most exciting step to get every child with retinoblastoma cared in an optimal way. And you can go to this website. I think I will go into it in just a minute. This is the URL. The username's demo user, and then capital D EMO 1234, really secret codes, and you can see all the details about the children with retinoblastoma that are entered into it. So I'm going to jump out of here. Log in. It logged me out. There I am, demo user. Can you see it? Yes. And I log in. And we see a whole list of patients. So these are all real patients, because we can't make up a case history for a real retinoblastoma with images and everything. The children know they're here. They've picked their name. We'll go into Oliver Twist, and their names are changed, their date of birth changed, etc. The child's not called Oliver Twist. So here is the legend. You see all of the codes are here. And Dr. Fuda really was very, very smart, because he just immediately knew exactly what had happened to this child by looking at all of this. The red is the staging EUA. I'll go into that in a minute. The events that apply only to the right eye or the left eye only show like that on that eye. And you can see this child has had for the right eye a whole lot of treatments, including intraarterial chemotherapy. What isn't showing on here is that we actually took out that eye. But I'll come back to that. The lines are treatments like systemic chemotherapy that apply to the whole patient, so they go across the whole thing. And included is also, you can see the little green line, that's the genetic testing, which is, of course, a whole patient treatment. So I'll enter this EUA. When you point to it, like you just saw me do, you see the date pop up. If you double click when the date's showing, then you go straight into the event. And these are, first fields here are just text. I won't bother you with those at the moment, but you can go in and look at it. It gets fun when you get to tumors and findings. And we draw with the mouse, or it's even more fun and more accurate if you use a pen on a tablet. And you pick up the tool over here, and you, like I'll double click on retinal detachment, for example.
I think you got it edit.
Oh, thank you. See, would you come and work with me? I'm going to put you on tour worldwide to teach everybody. So I go, and now I can edit the retinal detachment, and I pick up the tool, which is blue, because that's the color code for retinal detachment, and I can go over top of the tumor here, for example, if I felt there was a bigger retinal detachment. And the minute I stop moving the tool, it shows me the quadrants that are involved in the retinal detachment, because it's a vector coordinated diagram. I don't need to tell it that I'm putting this in the left eye. It knows that I'm drawing on the left eye. But I'm going to cancel that because I don't want to save that, because it wasn't true. Then I would go, I'm going to jump over to procedures, just because it still uses the drawing. And we'll come back to diagnosis. So now the legend items that I've actually used in the drawings are showing in the top. So I can still remember what they mean. Of course, once you've done it a few times, you don't need to see that. But if I wanted to laser, I can still not save. So now I'll pick up the laser, and I would never do this at this stage. But if I wanted to laser this tumor, I would go over there and I'd put laser burns around it, etc., and indicate that I'd lasered that. And it would give me the option to say which kind of laser did I use, and what power, everything, all the settings. I could score that. I'm going to cancel that too, because I wouldn't really do that at this stage in this eye. And the other things are all down here. So if I add a procedure, say I enucleated an eye, that actually maybe I no, I won't do that. I'll mess up the database too much. Then I would go back to previous page, and that doesn't save anything, and there I am back to home base. I need to go back into here to show you the staging. But you see, I'm trying to click without seeing the date. There, now it'll work. The bigger the screen, the easier it is to aim. And I'm going to go into diagnosis. And this is where we determine what the staging for each eye is. And all you do is record the size, the location, how close it is to optic nerve and macula, and other serious features, and the presence of seeds. It's collecting all that data, and then it generates the stage. So if I jump down here, you see both of these eyes are T2B, so they both have seeding. And that would determine here, if I changed that and made it worse, you'd see this, and recalculated, you'd see it there. If I take away bilateral retinoblastoma, I need to edit again, I won't waste time doing that, then it would change it from H1 to the H0 or HX. So back to the timeline, and you can see that we've scored the whole T&M staging up here, and it reads that automatically. So you can understand a lot about this patient. You can see how it's fantastic for sharing patients. Anyone in the whole team caring for that patient could see exactly the same thing, including the parents, and I'll come back to talk more about that. I'm going to go back to the PowerPoint, I hope. Good. And I had slides here on this particular child, the same one, where I've now got it more up to date, and I added the vision. And you can see the eye that was enucleated has 2400 vision. The other eye had good vision, so we'd done well in one eye. That was the staging. I've seen all of this, seen all this. Oh, I didn't show you the pictures. Yes, we upload pictures to images, so it does collect anything you want, and any kind of image, including pathology, can be uploaded. So when this eye was at this point, we were failing to control the tumor in an eye with 2400 vision after a whole lot of treatments. Here you can see yellow, so that eye's not well controlled, and this one is beautiful. And so we enucleated. So the whole team, which could be Mexico City retinoblastoma as one team, the 3 hospitals that are doing it, or more, and more centers, could be all seeing the same patient. All the different people involved in the care of that child would be looking at the same data and entering data as they do it. So we update the database. We've used this in SickKids, the previous version, for 15 years, and we update it every time we're in the OR when we do anything. And the images are uploaded slightly later, but it's all done. The drawings are done in the OR, and it's really fast. It's not so fast if you put a whole patient in, and you have to go and look for the records, but it's very fast when you're doing it real. The patient, the family doctor, the guardians can view. They can't make changes, but they can view. And the family invites the people who will be able to see their child's record. So if they want me to consult on their child, or you ask the parent to invite me in to see their child in the database, I just get a new login and I go in and look at the child. And you don't need to send me pictures by email. You don't need to send me doses of drugs in 5 different emails, which is the case we got from Montreal recently. But we really were lucky. We had a observer resident from New Orleans who spoke Spanish. The family in Montreal spoke only Spanish. We saw the family in Toronto, baby with two really difficult eyes to treat. And he took all the many emails from Montreal, put all of that into the database, and the patient's in the database now, and called Diego, so you can go look at this child. And we then had a conference call with the whole team in Montreal and our whole team in Toronto. But we all were sitting looking at the database. And we didn't tell them we were going to do this. the doctors, the patients knew we were doing it, the doctors didn't. So we dictated just on the phone the URL. They typed it all in, and they all were looking at the same thing. It was really quite magical how it brought everyone together. And that's why we're so excited that we can reach 0 deaths for retinoblastoma globally. It also makes the whole team work together. It becomes a team, no matter where you're located anywhere in the world. So we hope to eliminate the major causes of death. First of all, it's complex. It's a terribly difficult disease. The pediatric oncology group, whose meeting I was just at 2 days ago, has changed pediatric cancer completely by a series of iterative, formal, rigorous clinical trials. There is no data like that to support any care for retinoblastoma. No clinical trial has been done that amounts to anything in retinoblastoma. They're spread out too thin. There's not enough patients in any one place. But then you've got 2 different eyes with 5 tumors in one and 3 in the other, and the vision problem and all the rest of it. And poor communication. And so our tool, which we now call, this is our new 1-week-old name, brand, because we're told we have to do this to get the kind of money we need to make this actually move forward. Depict Health is a service to the retinoblastoma team for communication. We do not hold the clinical data. We hold just a summary of the data. So we don't know what the hemoglobin was on any day. We don't have the thick charts that every hospital has, but we have the important things for retinoblastoma. And then one of the biggest problems in retinoblastoma is that the doctor selects the treatment, and it's the doctor's opinion. So it's really an obvious example in intraarterial chemotherapy, which has swept the world because of good marketing. Each time they do a treatment, they use different drugs and different amounts of them, depending whether they had a coffee that morning or not. There's no protocols. So how can you learn anything about what's the best treatment in that way? So there is no standard of care and a uniquely failed evidence base for retinoblastoma. So the changes will be we hope the Depict Health becomes a guideline and a checklist. It improves quality of care, communication, no matter where you are. It includes parents and patients, and they will be the unpaid validators of whether the data is correct. They will know if you've got a wrong date. They'll know if you forgot to put in that you took out the left eye. You'll hear about that very quickly. And these patients with RB1 mutations all have a lifelong risk for other cancers. And Depict will show the scheduling annual MRIs or something like that for the rest of their life in the timeline. So here's the way it's organized. At the moment, it's not officially happening yet because we haven't got the secure login quite finished, and we're making improvements to it of all the little things we wanted fixed. That's happening right now. By May 31st, both of those computer groups tell me it's going to be ready to put Sick Kids patients and Alberta patients in as the first test. And then we will probably go to Kenya next because they are eager for it, and they've used it before in a different format, and they're very different than us, so that's a really good test of it. And then we'll go everywhere, and I hope Mexico. The steering committee, the operations committee, and the working groups will be comprised of parents, patients, and the clinicians from all the sites. So people from the sites will rotate through these committees and serve on them in different ways. So it's really all run by all in the circle of care of each child. Will all be working to make this work. Once there's data in here, then that coded data will become research data and available for studies. Each center can have their data just by asking for it, for their patients only, and they can do what they like with that data. But when they join with another center or 3 centers, that will go through this committee process to be sure that there aren't 2 centers doing exactly the same, or many centers doing the same thing, and encouraging everyone to work together and make properly powered big studies. And then, really exciting, the machine learning will study this on the fly without protocols, but it will be looking for signals that correlate with saving eyes or saving lives. And that will then be later feeding back automatically to the patients and to the treatment choices for the next diagnosed patient. So that's our model of how it can work all around the world. I'll just quickly, how's my time? I'm all right? Okay. So we're going to jump over into exciting new things, the precision personalized care, which is very buzzwords for cancer today, but we've really been doing it for years in retinoblastoma. For example, this Edmonton family, and they're not secret at all. If you put in triplet retinoblastoma, you will land on this family. I think they're the only case in family in the world to have triplets with bilateral retinoblastoma in all 3 kids. So we did their genetic testing and determined that each of them carried the same mutation in their blood. Testing their parents did not carry the mutation. We could not see that mutation in their blood, but we put an asterisk on it because they might have still less than 1% of their cells, and we're only testing blood. We're not testing sperm or ovum. So we don't know if there's not some fraction of cells there that could result in the next child having retinoblastoma. The older child, when tested for this mutation, didn't have it, so that's a true H0. That child has no risk for retinoblastoma, nor that child's offspring. They had another baby, who also is a boy, and that child was tested at birth, because the risk was so low, so only tested at birth, not before birth, because it was less than 1% risk. But at birth, it was found that the child was H0, true H0. Baby never needed to be seen by ophthalmology, never have any examinations. Normal kid. So we've compared delivery at birth without prenatal testing. That's the postnatal group here, where they were HX until they were born, even though they had a parent with retinoblastoma. We didn't know until the day they were born. These ones were tested for a parent that was already H1, so we knew what to look for in the baby, and they were tested before birth and delivered early, and they had much better outcomes from many points of view of leading much less invasive therapy and higher quality of vision in 2 eyes. Here's an example of another family. I treated the mother of our new patient in 1989 to 92 or so, and we were able to save 1 eye. 1 eye was removed, and she has 20/20 vision in the eye we saved because her tumors were nasal, and we treated them only with laser. Her mother had died of retinoblastoma. She'd had both eyes removed by a very smart ophthalmologist in the 1950s, when that was the best treatment for bilateral retinoblastoma, so she was able to have a family and meet her grandchildren, and then she died of sarcoma, a second cancer. So this baby was conceived and found to have a prenatal test showed that this baby actually carried the mutation, so we delivered the baby at 36 weeks. And that baby was born in Edmonton, where they live. They looked at the baby, couldn't see any tumors, and then we all realized that they didn't have an optical coherence tomography for handheld OCT, and we did in Toronto, and we do RetCam and OCT awake on these babies until we see something. So when the baby came to Toronto, and they lived there for 6 weeks in Ronald McDonald House, mother and child, so that we could do this every few days. We looked at the retinas the first time, and we also saw no tumors, and then we did OCT, and you can see here on the right eye, you don't see any tumor. There is the tumor shown on the OCT, and they're always in the internuclear layer. That's where the cell of origin lies, even though they have cone photoreceptor properties. And I think that's created a big, very fun debate between the biologists who show cone markers in them, and beautiful papers showing that they really are like cones, and our data showing that they're always in the internuclear layer, not the cone layer. So I think loss of the retinoblastoma gene in the cell that's a cone precursor blocks its ability to migrate, because it's in the internuclear layer when it's a precursor, and it can no longer migrate to become a cone. So that's why lets us be all in agreement. And that's published in a very interesting paper looking forward on retinoblastoma in Nature Reviews Disease Primer 2 years ago. So what we did was laser it, but it's a little hard to see. So we put in one laser burn and we say, yes, we actually are seeing, we're lasering in the right spot. And then we did a little more laser because you can still see the tumor there. And this is a few weeks later, and this spot looks like there's no tumor, but we keep following with OCT. And this subsequently has shown that we didn't quite kill the last tumor cell and it had a recurrence there, but we see it when it's only visible on OCT, and we've lasered it, and now at the last visit last week, this child has no recurrence here. The other eye had a more dangerous tumor, also really totally invisible, and this is the tumor right there. And it was treated with laser, one laser burn. You can see there's the tumor is a little more obvious, and the laser burn is deep. You can see it shows how much the pigment epithelium is absorbing the laser light and causing the heat, because the inner layers haven't been heated for one burn. Then we did more burns. We did 8 burns, and then we said that's enough. And here's the scar later. We've never touched that scar again. So 8 laser burns did all the job. And it shows, again, how much the laser depends on heating the pigment epithelium to absorb, to generate the heat, because the axon layer is intact across the scar. I've never seen that before. Pretty exciting. But this is far away from reaching no deaths. This is optimizing vision. There's the tumor, and it was 0.4 millimeters. But we actually, subsequently, the child had another tumor show up on OCT in the other eye, but it was fairly large. It already had made a dent in the internuclear layer, and we hadn't seen it before. So we went back to 6 weeks earlier. Our OCT had missed it. We watched the OCT as it's being done in the OR, and we hadn't noticed this tumor. And it's 0.2 millimeters big. But going back retrospectively, you can see it was there. And it only was in one slice. So the next slice showed nothing, on either side of it shows nothing. So that's how precise we can get for treating retinoblastoma. This is a guideline, the first guidelines in retinoblastoma in the US ever. And it's for the screening for whether the child has high risk, medium risk, or low risk, or general population risk. So general population, so an proven H0 patient falls into this group. And the H1s are high risk, or way up here, 50% or 100% if they're H1. And these are just the follow-up schedule. So this is published just very recently. It's actually, I think 2018 is the date on the paper that's come out. I'll jump to other innovation, the exciting innovating treatment things that I hope will save more eyes and therefore maybe more lives. Although early diagnosis and early enucleation is the best way to save lives. So we have a little paper coming out summarizing new things in retinoblastoma, and we built this table for the different treatments. And chemotherapy can be systemic, intraarterial, or intravitreal. I'm not going to go into depth on any of these now. Focal therapy is basically laser or cryo, although we did have subtenon's injection of chemo for a while. It's not very effective, and I think the intravitreal melphalan has replaced the need for that. It was pretty toxic if you used carbo and didn't do very much with topotecan. Radiotherapy, external beam, is almost obsolete, but we've just, 2 or 3 years ago, we did external beam radiation for the last eye in a child from a very remote part of Canada who we weren't going to be able to save this eye that could see without using radiation and finishing the job. But it's very, very rare. Stereotactic is, in theory, sort of talked about as if it's going to be safer for second tumors than external beam radiation, but I don't think it's true. It's certainly not proven. And brachytherapy is very good and really excellent for a particular need when there's one tumor, particularly one that's seeding or something, to control the source of those seeds. It's very, very good. And under surgery, enucleation is by far the most important procedure. But now I'll introduce pars plana vitrectomy for endoresection of the tumor and the vitreous seeds, which is very radical. And this is our paper that we had to fight really hard to get ophthalmology to publish it. The editors, the reviewers weren't so emphatic, but the editors were frightened of the heresy of talking about taking tumor out of an eye with live tumor out of a retinoblastoma eye, that would kill children all over the world. It's not true, and the intravitreal injections for intravitreal melphalan have shown us that there's not a lot of risk if you do it carefully in the right time, and you can take seeds out of the eye. So John Chow, who I mentioned earlier in China, is seeing half the patients in China by traveling through these different treatment centers. I followed him center to center, and I can only do it for 2 days. Then I'm exhausted. He goes on to the next center, and I go home. He sees up to 50 patients under anesthetic, and in 1 day. And I've counted the amount of time on each patient. It's 8 minutes on average. Now, if he needs laser, he just says laser, and the laser is delivered to his head. He doesn't use the indirect much unless he wants to look for a specific reason. He uses the RetCam, and he uses the RetCam beautifully. He sees absolutely the whole retina. He scleral depresses the whole eye and takes pictures of everything. And I know he has all these pictures because he carries the medical record of all these children in his contact list, in his phone. And he has the images from the RetCams in all these different centers, all loaded into his computer. He doesn't have very good backup, but there's some backup. So when we write a paper together like this, I can ask him for the pictures or this or that, or in the database which he sends me in Excel, there must be a date wrong. These dates don't make sense. The birth date can't be after the date of diagnosis. And it'll be in an airport somewhere, and he will text me back the correct date because he has everything with him. So this is a very unique person. And he invented this vitrectomy. He said, I just can't keep treating these kids for 3 years, and they're going to lose their last eye. So he said, why don't we take out the vitreous seeds? This is the summary of the paper. There were 21 children in the first half of 2013. And now I have the data in my computer on 400 children maybe it's 300, in the second half of 2013, and the next year and into the middle of 14. And I have to sort that out, and we'll publish that next. There were no known deaths at the time of publication, but there was one lost to follow-up. I'll come back to that in a minute. And in the end, the final vision was quite useful and better than legal blind in 74% of these eyes that otherwise would have been removed. And these were the only eyes in these children. They didn't have another eye. And they had some treatments after, and I'll go through the details. So you use Depict to display their treatment, and every child's course is illustrated without all the little details because it wouldn't all fit. And here is the pars plana of vitrectomy and their vision for all these children. So these ones needed nothing more. This is years after the pars plana vitrectomy and after diagnosis. So you can see it's a pretty solid treatment. These ones had intravitreal melphalan these ones had systemic chemotherapy after the PPV, but because the other eye that was enucleated was a high-risk eye, so the chemotherapy was given for the left eye, not the right eye that had the PPV. This group, again, long time, good outcomes. The last group are the ones that PPV failed, and so there are 4 patients here. A second PPV was done in this eye, but it still failed, and then these 2 eyes were removed with low risk pathology. So doing the PPV and delaying enucleation of that eye did not increase the high risk for extraocular disease. This child had a second PPV, and that worked, and the child has a 20/50 vision in this eye. This eye is the one that is lost to follow-up. 3 PPVs, vision still 2100, no evident risk factors for death, and the parent said, we refused to still let you take that eye out, and disappeared. And so in the publication of this paper, the editors correctly argued that loss to follow-up has to be considered dead. Subsequently, we found that the child indeed did die. So we've submitted a letter to the editor about our paper that is in press now, saying this child died. The child did not die of pars plana vitrectomy. The child died of parental refusal of enucleation. And that leads to the over-focus on saving eyes with retinoblastoma globally, which has been largely promoted by intraarterial chemotherapy, which markets itself as saying no eye should ever be lost with retinoblastoma. And that's causing deaths because the eyes are kept for too long until they spread out and the children die. And there's a lot of this all around the world. So this child died of wanting to save an eye, died of the false hope that this eye could be saved. So now when we see a new patient, no matter what stage the eyes are at, and certainly if they're bad eyes, we, right from day one, and every time we see them, we say, yes, the child's doing well today, but we never know until the job's really finished, we still may need to take out this eye. And so that they're ready to know that life is worth more than saving an eye. And life is worth more, the child's job in life is to play. They're meant to be really learning in those first critical years. And if we keep them in hospital and do all these treatments to them and they never have any chance to feel well and play, and then lose the eye, and then lose the life, we've done a pretty big disservice to the child with retinoblastoma. So just a quick, this is a child in Kenya, and I've worked lots in Kenya with retinoblastoma, and Helen Damaris is really working very strongly in Africa on retinoblastoma, which is important because that's where 70% are dying. She's the one that can actually change the whole pattern there. This child in 2015, I'd seen the child in 2014, and then again in 15, and at that time, this tumor, normal macula, this tumor had seeded from here where they were lasering around it and not controlling the tumor, and it was out all through the vitreous. But I'd just been in China, and I knew that you could do a vitrectomy and save this eye. The only other option was to take out her last eye in Kenya. They didn't have intravitreal melphalan and weren't going to be able to get it. They certainly have retinal surgeons who could have done that, but all the logistics didn't work for it. So we organized for her to go to China, and in China they helped. We paid for a lot of this from Canada, but it was delayed because they didn't even have birth certificates when we started this, so they couldn't get visas to China. But ultimately they got there. They had the PPV, went back to Kenya, came back three months later to take out the silicone oil, which had been put in to stabilize the retina, and this is her now in long-term follow-up 20/20 vision for her lifetime because of this trip to China. So if you look at costs, it cost about $12,000. That's all it cost, this whole expedition, with a lot of extra people doing things for free, like China. The hospital didn't even charge. They got so excited about doing this project. And but it shows that you can do this, and we can reach the whole world. And families that don't even have a birth certificate from the rural parts of Kenya can actually go to China and get back home safely and happily. So this is our new byline for the Depict Health database, which is only part of what I'm talking about. But I'd appreciate your feedback privately or publicly, whatever, on our new byline, which is Full View for Life. We need to put that below Depict Health, and then maybe someone will give us big money to run it all. Thank you.